Good afternoon, everybody. So, welcome to our live Friday webinar. So, today it's going to be like understanding critical lab reports, what to flag immediately. And our webinars are like supported by HSSC. And so glad to see you all today for this webinar on time. So let us go inside that. So before beginning up, so I would like to take you all to the quick introduction about us for the benefit of the newcomers. Like we have been established from the year like 2018, and we have been committed to providing comprehensive training program designed to enhance the capabilities of the nursing professionals and also equally the other healthcare professionals. So far now we have 10,000 plus healthcare professionals who have logged in, and 75 plus hospitals have been like having a network with us, and 50 plus courses have been launched. And with these 10,000 plus nurses who have upskilled by us, we will also like want you all to join this skills for med growing community, where you can upskill yourself and then reskill and then build your confidence and transform your patient care like amazing in your healthcare system. So what is this skills for med logo actually talking about? It's like we have the pyramid type of logo. It actually has some meaning behind that. So we have 4 stages in the pyramid, where the stage 1 focuses on service excellence skills. So the service excellence skills is for the person like newly going into the healthcare system as a healthcare professional. To start up with, you should know a basic things. For example, we used to cover inside like infection prevention basics and the communication professionalism and how to maintain the etiquette. All these things are covered in the stage 1. So when it is all set, now we are ready to go to the stage 2, where we are focusing on the core patient care skills. It's about the bedside procedural skills. It's not like you're expert in one particular procedure. It is about like you're becoming a clinical expert. It means it's not about like competent in one factor. You have to be, as an individual, you have to be like clinical expert in all the aspects of procedure when it comes to. So that is what we are actually preparing the healthcare professional in the stage 2. So when it comes to stage 3, I have been become a clinical expert now. So it's not a limit here still. So we have to deep rooted in our own specialization, or else that's the time where you're going to choose your specialization where you can be excel at it. For example, the courses which is covered in the specialization skills is like labor room upskilling program, emergency room upskilling program, and not only that, it is about like becoming a clinical instructor and also becoming an infection control nurse. So these are all the important things, and also about the critical care nursing professionals. So this is about the specialization course. So this is the limit? No, we have another stage 4, where you can really focus into like growing yourself as a great leader in the healthcare professional. So which we have the 2 pathways in the skills format. One is the vertical path, another one in the lateral path. Vertical path, as a nurse, we will complete it off and join in the hospital. Our ultimate goal is to become a CN of the hospital. So it is like a vertical path, where you will take up from in charge, supervisor, ANS, DNS, and then growing up to the higher level. So the lateral path is like another thought of process, where you can see yourself as the CEO of the hospital, where you actually go deep dive into the operations dynamics, where you actually doing it up in a great job. So this is actually about the 4 stages where we talk about in the skills format learning pyramid. So here is an announcement. It's about the infection control nurse course program conducted by Skills for Med, collaborated with 𝐂𝐫𝐢𝐭𝐚𝐧𝐝. I have to say all this course highlights are too comprehensive, where we have seen a lot of nurses who have undergone this program have done their successful projects and then had their transition career as an infection control nurse from the bedside journey. So this is the self-paced learning, and we are running a special offer like 24K of courses now given away at the cost of 17,700 inclusive of GST. So to know more details about our course and the details about our skills for med programs, you can contact Ms. Jayanti. Her number is on the display. She is our admin manager. And to know more, you can also visit our website, which is www.skillsformed.com. Yes. So how will this webinar benefit you? Actually, to be like, no, frankly speaking, we are today in the topic of critical lab alerts. It's not just critical lab alerts. It's going to benefit only the nurses. It is like widely speaking, all the healthcare professionals who are handling the patient lab values and the treatment modalities, which includes the lab values are aligned with, for example, the nutritionists, the lab personnel, equally the doctors, eventually the night no shift DMOs, like whomever is in the no in the healthcare system handling this lab values are going to get benefit out of the session, where you will be after the session, at the end of the session, probably you'll be able to highlight all the red flags which is going to come into your lab reports. So this session is going to be run by myself, like Stella Townsend. I am the training manager in Skills for Med, and equally sharing this webinar with Dr. Parivalvan Rajavelu. He is the consultant surgeon, Sundaram Medical Foundation, and he is a great visionary leader and the founder for the Skills for Med. He is the person with the quality, and he has various key roles in 𝐂𝐫𝐢, and his vision have transformed the Skills for Med, which is like upskilling the nursing professionals, not just staying at the bedside, who's just having a structured program for all the nurses to become a leadership role and to achieve the great heights. Welcome you, sir. And coming to the topic, just highlighting again for the
Thank you so much. Yeah.
Thank you, sir. So to the webinar participants who have joined now quickly at the Haribari time. So this is the topic we are going to focus on today, understanding the critical lab reports, what to flag immediately. So starting it up with, so we'll start up with the poll question here. Let me launch the poll. Before getting into the session, no, we are very eager to know like what is actually the understanding of the participants about this. So I have launched the poll. So time have started. So we have 5 questions on the display. You can start answering to these questions. So the time is running. You can dive into this poll directly, and you can start answering to the questions.
I think we need to reassure them that we are not testing their knowledge, but basically,
Yes.
what is their concepts and practices of this critical results cycle is what we are trying to find out from this poll.
So true. Thank you so much. All the participants have started to actively, participating into this poll activity, I could see. So 1 minute passed, like we have 2 more minutes left. Okay, you all have 1 more minute left. Yes, I'm going to end this poll now. Thank you so much for all your active participation. Yes, I have ended the poll, and no, I'm sharing the results. I would like to no, invite Dr. Pari to have the discussion about this poll right now here. So,
Thank you. Can you hear me?
yes, sir.
All right. So let's quickly go through the poll. First question is about the confidence in using the S-bar method about abnormal, and I think majority of them are confident or somewhat confident, so almost 83%. And so that's very good to know. And how often do you come across lab results that need urgent reporting? The frequency of critical results coming in every week and every month is the most common. So again, this accounts to almost 90%. So it's a very, very common issue in any acute hospital. So that's the reason, one of the reasons we wanted to deal with this topic. And
Yes.
does your hospital have a clear protocol? I think almost 80% say yes, and about 15% say yes, but I don't follow it. And the rest are saying that they're not sure or no. And what's your biggest challenge while dealing with abnormal lab reports? 50 of them have told the doctor doesn't respond quickly. So that's almost half the respondents. And about another 30% are saying not sure which values are critical. I think by the end of this session, no, we will have a clear idea about that. Don't know
Yes.
whom to inform and unsure how to document it. I think we're covering all these things in our
Yes.
webinar today. And if dealing with an abnormal lab results felt like a movie, which one would it be? I think our team is getting very creative in the question.
Yes.
So, Mission Impossible, I rushed to get the doctor before the time runs out is about 60%. So, and Dr. Strange, I'm trying to understand which results he means. Intern, another 20%. I'm learning the ropes and doing my best. And don't look up. I know it's critical, but no one listens. That's a small.
Yes.
So that's a nice way of looking at this problem. So there are
Yes.
several pain points as you can see. So the one is the main thing is the response from the doctors. So that's the reason actually we widen the scope of this webinar. I think this webinar is more important for the doctors than the lab technicians or the nurses. I think that's very, very important. That's one of the reasons we reached out to as many doctors also as possible. And another thing is no clear guidelines on what critical results are. You need to have a list of critical lab tests, which is communicated to everybody. It may the lab people may know, but actually people working on the clinical side may not have a very good idea. And the last issue, which yeah, no, looks about that, I know it's critical, but no one listens. So this is a very painful, situation to be in. So I think this poll, thank you so much for everyone who's participated. We were very, gratified to know that, when we did the statistics about our webinar, people attend from all over India. No, we were actually started in a very small way, but now it's grown and our respondents are from all over India. So this is actually you could say it's a national view of this particular problem of these three important topics, I mean problems, and I think we will deal with that. So with that,
Yes.
I think we can go ahead, with our webinar. Thank you so much,
Yes.
Stella. Yeah.
Yeah. Sure. Sure, Doctor. So I'm sorry. So today's agenda would be like mastering the critical lab recognition in 40 minutes. You can see amazing image how we are going to take this session now. So starting from the initial knowledge, you will have the basic understanding like what are all the lab reports, and then going into the red flag values, like identifying the critical lab results, like what are all the important lab results, like for we can cover it up, and then how to communicate if you're getting those lab values, and we'll be looking into one case study and how to resolve that, and then finally we'll have the Q&A session and action planning, like focusing on skilled in patient care. So this is today's agenda. And let's start with a scenario. Always our webinar starts with a scenario, so everybody have some catch up minds, like what is actually going to be. Like now the clock shows like 2 a no 2 a.m. here, the 3 a.m. the lab results, that changes everything. So what happens is, like, here's a nurse, ICU nurse, like 2 a.m. shift. The troponin result have come into our desktop, which shows like 8.2 nanogram per ml. So the normal value, as you all know, is like less than 0.4. The patient now, when she's looking at, no, besides the score, the patient is sleeping peacefully, no chest pain, no symptoms, nothing. Her next decision is going to save a life. Yes, of course. If imagine you are the nurse Shalini in the same, in the ICU room. If you're so much intellect in identifying the critical alerts, then it's going to be amazing for your shift, where you're going to prevent the patient from the massive MI attack. So the observation is key to save the life, and no, a vigilant healthcare professional can do that with the expertise knowledge. So, Dr. Pari, could you please tell us, like, what are all the critical lab values that demands the immediate action in the health, in the bedside?
Yeah, thank you. See, I think the understanding in 40 minutes, it's very difficult to cover all the lab values, but what we wanted to make sure is that everyone goes with a very good idea of what critical lab values are. So even if that particular test may not be on your hospital list, you will have a pretty good understanding when you get a lab result whether it's critical or not. So a critical lab value is any lab value which, as the name suggests, critical here means time critical. Okay, if you delay the treatment, so that is the time, then the patient is has will get into problems or will undergo some sort of complication or harm. So any such lab result is known as a critical lab value, and these demand immediate attention. So many times when I go around various hospitals and talk about critical lab values, they only look at it as an NABH requirement. So this is this sort of mentality has to go, because though NABH introduced it, it is such an important part of actually preventing patient harm and preventing patient complications. Because this we used to do it in a very informal way even before. So any nurse who sees a hemoglobin value of maybe 3 or 4, or any lab attendant looks at this report, immediately they're going to call the doctor and they were informing. Not that we were not doing that before NABH. But what NABH has done is actually formally made a process for this and made sure that this is standardized. See, there may be some shifts where the lab attendant or lab technician is very vigilant. The other shifts, maybe the nurses are very good, and there may be some shifts where the doctors react first. But there, this communication which happens between three different people many times fall between the cracks. So that is the reason NABH formalized the whole process and told the importance of critical lab values. So that has now come to the forefront, and it is very much important because it saves lives. So for example, it recognizes life-threatening abnormalities like the one we just spoke about, high troponin value. And the very important thing is to know your facility's critical limits. So every hospital should have a list of critical lab values. So this critical results are not, though today we are talking only about lab, it also pertains to imaging. So if you do a CT scan and the CT scan shows an acute hemorrhage, that is a critical imaging result. And this needs to be immediately communicated to the clinician. So in its sixth edition, I think NABH has now expanded the concept of critical values to also imaging results. Now, both the lab and the radiology department need to look at their scope. What is the group of patients they are treating, and what are the tests they are doing, and for each of these tests, come up with a list of critical values and communicate this to the lab and the radiology staff, to the nurses and the doctors, the clinicians who look after the patients. So that is the whole concept of critical value, and the facility should have, each facility should have a composite list of all the critical values that are that can happen in that particular hospital. So this cannot be standardized. You can, it has to be from hospital to hospital because the scope of practice varies from hospital to hospital. The other thing is understanding normal versus panic values. Panic in the sense, which do you actually, rush and do things. So this is something I think we can't cover in this webinar because we're not talking about a class which is normal, which is abnormal. We'll give you some examples of critical values and why they're important so that you get an understanding. And this can be extended to any sort of critical value. As I said, it also, involves imaging critical values as well. Most important is mastering that stat mindset in the sense this has to be done now. No, that is the meaning of stat mindset. So when you
Yes.
see a critical value, you got everybody, that lab staff, the nurses, and the doctors get into this mindset. Or this needs to be solved right now because every minute of delay is actually going to be harmful for the patient. So that's the whole basic understanding of critical lab values that demand immediate action. And now I think Stella will give some examples of these critical values. Though we can't do a very comprehensive job in this 30, 40 minutes, I
Yes.
think, we will go organ by organ and we can tell what are the critical values in each particular organ. I think thinking in this organ-based fashion, make sure that you understand what damage you can do to the organ by delaying, if you delay things, if you see a critical value. So that's the whole concept of why we have chosen to represent this by organ. Please go ahead, Stella.
Sure, doctor. So, as Dr. Pari was explaining about, we are going to go with organ by organ, starting with the cardiac lab, related reports when hearts are in the danger. So, what are all the three important values we'll be focusing on is about the troponin. So, troponin is actually a protein which is released when the heart muscles are getting damaged. The myocardial damage is happening. The protein is getting released. If it is more than 0.4 nanogram per ml, then potentially the patient is going to have the MI kind of onset. So that's the one we are going to focus on. And the second thing, 𝐂𝐫𝐢𝐭𝐚𝐳, if it is more than 25 nanogram per ml, that is again, it's a kind of enzyme which is like released more when the myocardial damage is happening. And the third thing is about BNP. If it is more than 400 picogram per ml, then you have to assess and treat the heart failure crisis. Already the damage have occurred. Then for the 𝐂𝐫𝐢𝐭𝐚𝐳, if it is more than 25, then we have to look in for the ECG changes, and all the enzymatic study will be done repeatedly. And for the BNB, almost you have to call the cardiologist in, and things has to be started. So for all these three parameters, it is very important you are alerting the cardiologist. And this is like time is muscle when it comes to cardiac. Like when the myocardial damage is happening, all these three parameters are getting fluctuated. If it is increased, then the patient is at the risk. So
Yeah, why
yeah.
is the rest, troponin critical? I think here we have tried to explain it with the acronym HEART. So one is, the troponin indicates, as Stella pointed out, it is a heart muscle death. So when the cells are dead, then they release this protein, and there is an emerging myocardial infarction, which is can happen, or it is happening. And it also could be a full-blown acute coronary syndrome. And also there is the rupture of the ventricular wall, which can be catastrophic. See, the whole concept about the intervention, the primary intervention for cardiac events, so that's why the primary CAT has become very popular, is if you do it in a timely manner, you prevent muscle death and thereby keep the ejection fraction of the heart optimal. If you know the muscle death happens and there is muscle necrosis, then the heart function goes and the patient is affected for life. So that is how important these values are in preventing the not only the complication, but the long-term outlook for the patient.
Yeah, thank you. And next value is about the metabolic emergencies. Now, the life-threatening imbalances when you look into the lab reports. For example, if you look into the glucose reports like less than 50, or no, when it exceeds 400 milligram per dl, glucose actually has some no functions with the brain. So even when it is goes less, the patient becomes unconscious, and then the patient will have the seizure kind of effect. And if it is no exceeding more than 400, then the patient will have a complaint of no, still they can go till the comatose stage if it is more than 400 milligram. So this is what happens when the glucose like having a decreased no less than 50 or more than 400. And when it comes to sodium value, it is like less than 125 or more than 155 milligram. It's abnormal result. When it comes, the sodium also equally have functions with the the brain involvement. So when these abnormal results are coming, you can possibly monitor the patient for kind of complications, like patient will have jerky movements or seizure type of attacks with the patient. So that's what's going to happen. You're going to closely monitor the patient and immediately inform. And for the potassium, this is actually equally contributing for the heartbeats, like where the heart is pumping. Like for example, if it is less than 3 or 5.5 milliequivalent per liter, poses a cardiac arrest risk due to cardiac function disruption, because the functioning of the heart get reduced, the pumping rate will get reduced because of this value. So possibly the patient will have such kind of complications. When it comes to calcium, if it is less than 7 milligram, this is actually the calcium all like contributing for the muscle strengthening. If it is less, then the muscles are going to lose its strengthening effect, where it the respiratory failure will occurs, because the lungs, the walls, everything is going to get weakened. So that is the result which comes out of like calcium is less than 7 milligram per dl. So these are the various, you may see a different kind of the glucose, sodium, potassium, calcium, but each component has functional defects on each organ. So that is what like earlier we were focusing to connect it with. So when it comes to blood work emergencies, the numbers itself tells a story. You are receiving a lab report where the patient is having hemoglobin less than 7 gram per dl. Obviously, that is the patient who is actually in need of blood transfusion, need the blood volume replacement. And if the platelet is less than 50,000, obviously the patient is the risk for bleeding. We take all the potential concerns for the patient, like for example, unnecessary pricking to the patient, or we may even taking the patient into the high risk category will prevent the patient from further injuries, because if they're going to get bleed, then they're going to get into the life risk emergencies. And third things is about WPC. If it is less than 1,000, then the patient is potentially having some kind of infections. So that's why the value is less than 1,000. If it is more than 30,000, then obviously patient is like going into septic shock, or into like more inflammation has occurred into the body. So this is like suggesting infection or the malignancy. And coming to the overall critical value, all this critical value requires the immediate physician notification. Rather, what should be done for the observation factor, it should be informed to the physician parallelly. Other critical value in hematology, because we have seen about the WPC and the platelet and the HB, equally we have the PT-INR and the increase about the D-dimer. So when it comes to PT-INR, you all know if it is so high, the patient is like having the bleeding risk, and also the liver is involved when it comes to the blood components. The protections all starts from there. So when it with the hematology, then the liver synthetic failure is happening. That's why the increased PT-INR. When it comes to increased D-dimer, then the patient is like going for the overcoagulation. Usually this occurs when the clots are dilated, it is getting solvized in the blood solution. So that is, if it is increased, then overcoagulation is occurring, organ thrombosis is occurring. Usually the patient would likely have the DVT or the pulmonary embolism. So it depends upon the where the clots have been existing. So this is about the other critical value in the hematology. So coming to the kidney crisis, we have seen about the heart and the hematology factor. When it comes to the renal factor, the creatinine, if it is more than 4 milligram, then the patient is like acute AKI patient, acute kidney injury. Immediately they might need the medical attention. It should be alarmed to the physician. And if the burn rate is like more than 100 milligram per DL, and the risk of uremic encephalopathy is necessitating like urgent intervention must be done. So there is difference between the creatinine and bun, even though it is from the same system related, then the actions are like different. And equally, when you look at the bun and creatinine ratio, it must, like, if it is more than 20:1 ratio, then it signals the patient is actually having the worst dehydration, or the patient needs the massive fluid replacement. So they'll be like considering for the bolus flush and the fluid replacement therapy for the patient. And for the severe cases, like all this three together, it's like hyping eye and the functionality is getting so critical, then the patient will go for the dialysis to correct their normal renal function. So this is again about like why is altered bun creatinine is critical. Yeah.
So basically, I think that I just want to talk about the bun creatinine ratio. This probably many labs do not report this ratio. Can you just go back one?
Yes.
So if you could see that if there is the bun rise is out of proportion to the creatinine. Suppose the creatinine is just 1.5, but the blood urea nitrogen is very almost 2 or 3 times normal. This indicates dehydration. So it's a pre-renal cause for this race. So this is a very good ratio that should be reported by many labs, which will alert the clinicians to the cause of the problem. When the blood urea nitrogen and creatinine rise proportionately, it is most often a renal issue. Okay, can you go to the next slide?
Yes.
Yeah, so as you can see here, it's the kidney function could be ischemia, that is a blood supply problem, or as I just spoke about, it could be just severe dehydration where there's not enough water available for the kidney to filter, or it could be because in some of the drugs which the patient is taking is nephrotoxic, or maybe just we didn't know that the patient had end stage disease. And the more important or critical thing is uremia, which is developing, which can be easily corrected. So this is the reason why both blood urea nitrogen and creatinine values are critical.
Yes. And coming to the next organ is about hepatic emergency, when the liver actually struggles. Like the value is like ALT or AST is like more than 1,000, then it like indicates the severe liver damage. And when it comes to bilirubin, if it is more than 50 milligram per DL, suggesting significant liver dysfunction is happening already. And ammonia, it's like more than 100, and then indicate the potential brain dysfunction due to liver failure. This is again like same like the glucose parameters, how it works. The ammonia is also like equally having some disruption activities with the brain. And when the patient is having elevated PTINR, this already we focused is about like suggesting the patient is having some impaired blood clotting ability. The potential patients will have risk of bleeding in such kind of patients. So again, it is like why is altered LFT critical?
Yeah, I think there's a very good mnemonic for that. Liver dies. And these are the causes of hepatic failure. Usually, we mug this up when we go for our postgraduate exam, right? So the altered liver function test indicate either a liver necrosis, whether it is hepatocyte damage, or ischemic hepatitis, viral hepatitis, ethanol, which is the alcohol toxicity, or rhabdomyolysis. People who do very strenuous exercise, sometimes this happens. The muscle damage happens, and the rhabdomyolysis releases these toxic tissues, which damages the liver. And again, drug-related injuries, infarctions, elevated enzymes, and in hypovolemic shock, prolonged hypovolemic shock or prolonged hypoxia can lead to liver ischemia, and that's known as shock liver. So that's the reason that we are focusing on these liver enzymes as critical values. And one of the things I wanted to point out, can you go back to the previous slide? You would see that actually, the ALT, AST, traditionally it used to be called SGOT, PT. We are
Yes.
looking at more than 1,000. So anything abnormal actually suggests liver dysfunction, but definitely anything more than 1,000 indicates very severe damage. So here we're talking not about abnormal results, it's about critical values. So if it's more than 1,000, then it means actually the liver is in danger and you need to intervene quicker. So I just wanted to make this point because some
Yeah.
people think that why are you having such a high value for these, where even 300, 400 raise actually is abnormal. But actually we are talking here about critical values.
Yes.
Thank you.
Yeah. And in a consolidated way, the big 8 critical lab values is like, if glucose less than 50 or more than 400, I've discussed already what is going to happen with the patient. Either the seizure effect, unconsciousness, if it's less than more, then they will end up with comatose stage. And with the potassium, like we have discussed already, and the sodium, the value is like less than 20 or more than 160, the critical value. And the hemoglobin, if it is less than 7, what we are going to do, like the blood transfusion, recommending for the blood transfusion. And the CBC count, if it is less than 50.
Platelet count.
I think it's a platelet count. Platelet count less than 50,000, what we're going to do. And the creatinine count is that more than 4 milligram per DL. Platelet count, again, I think some duplication have occurred. And the INR value, if it is more than 5, the bleeding risk, and the troponin more than 0.4 nanogram per ml, then the potentially patient is going to end up with the cardiac arrest. So this is like you can have like a ready recurrent, like what is Ilya image. Whenever you look into the lab reports, these are the usual values, not the usual value, critical value. These are the values you're going to look at it. So possibly to identify the critical value, I think you would have known like system wise what are all the values are like expected to be the critical. If it is critical, what has to be done and what can be monitored with the patient. So this is all about this. So now, as for now, we are now we have come across like what are all the critical lab values, what is there in our file, what we are going to get. So once you have identified that's the critical value, yes, this for this patient, this is the critical value I have received. So the communication protocol, that's the important factor which actually is going to save patient life. It's not only just identifying and getting to know this is the critical value, yes, I have found out. No, how you're going to communicate that and how you're going to take action with the patient to really care about the patient safety and improvise that. So for that, we have 4 different things. It's about like communication lifeline, so where you should have a proper structured tool to communicate this to the treating consultant, and the command protocols, whatever the doctor says, how we are going to carry out. I think this Dr. Pari is going to take us through in a detailed way. And also it's about the patient protection. It's not just about hearing to the communication and then you're doing something with the patient. It is about the documentation, which is legally, like all the healthcare profession documents are legally approved documents where you can save the hospital with your single documentation. So how you're going to document, how you're going to have the continuity of care to the patient with the communication protocol, and at last like critical alerts, the technology tools which provides the timely alerts for you all. So this is what we're going to do see in next few minutes. So starting with the structured tool, what I was talking with, if you have to communicate a critical lab report to a doctor who is actually the primary consultant, for example, for the patient. So how we are going to communicate? It's about important information. You cannot beat around the bush. You should have the structured tool that is called ISBAR. So the I, it is not like it's I, it's everybody knows it's about like identifying yourself from where you're calling and introducing the patient name, UHID, and from which hospital you're calling and which ward you're calling. And coming to the situation, actually what is happening now, as per the scenario, the critical lab value, what you have found it is going to be a first line statement. You're going to talk about that patient. So and so patient is having this critical lab value. For example, troponin you're talking about, you're going to say it is increased more than 0.4 doctors. That's the first situation you're going to talk about. Then the background is like, might be the patient is having no supportive disease condition related to the situation, that already existing cardiac comorbidities. That might be the no supportive background. And the assessment, what you have done after the troponin, what you have done, you might have taken the ECG, you would have taken the ECG reports for the patient, and it's ready in your hand equally to tell. When you're talking about the troponin value, you will be talking about the background and the assessment, what you have done, what is the report about that, and the recommendation. Of course, you have done all these things, but still you want that intensivist or the particular doctor to come and visit the patient, and or else to suggest some phone orders or the treatment, what has to be done depending upon the criticality. So this is the structured tool. When you communicate in this way, when you talk about the situation, the background and the assessment, what you have done, assessment in sense not about the vitals parameters, not about the temperature, pulse, about that. When you talk about the troponin, the first assessment part must be about the ECG. When it comes to troponin, you all know like what has to be done. So then the recommendation part, actionable step, maybe you can call the doctor, come and visit the patient, and to carry forward this. So this is about the structured tool. So the script, for example, for the critical conversation, here comes with the same scenario, the nurse whom we have seen, and the patient is about like Mrs. Chandni. So the nurse whom I'm going to call is like probably I'll be telling like I'm calling about Mrs. Chandni's critical labs, because that is the highlighting factor. You're going to say something. Background is like that patient is in the post-op day 2, multiple organ dysfunction. So MOD case is this patient. So you're going to say the background, because the situation is high, critical lab value. The background, already patient is in post-op day 2, and the patient is the case of MOD. And assessment, you have done the troponin assessment. So what is the critical value? Actually, you wanted to say to the doctor, and recommendation like need immediate intensivist consult. That is the point where the nurse have understood actually this patient need the intensivist consult right now to safeguard the patient life. So this is about the ISBAR scripted communication, how you can do with the doctor. So Dr. Pari, can you please tell us how to document everything? When it comes, it's very important. The documentations are very legal part and the clinical shield. Take us through much more in a deep ways to have a good understanding about that.
Yeah, thank you. This is something which is very important, and it's not just for documentation, but basically to make sure that the right actions are done. So
Yes.
the first thing is detecting the critical value. No, it's not clinical again. It's critical value, and so once a critical value is recognized, either you get an alert in your automated system, or you have found out that it's a critical value. The next step is to enter in the critical value register. So every lab should have a critical values register. So once the critical value register, critical value is detected, so that should be entered. And that once these things happen parallelly, and you then call up the particular ward in which the patient is going to be, and alert the nursing staff this is a critical value. Or sometimes if the hospital protocol is such that you can call the doctor, especially if it is an outpatient. So if it's an outpatient, then you need to call the doctor directly. So you need to alert the relevant clinical staff. And the next step is to document the message. So not only do you just call up, in the critical value register, there is a column saying what time you called to inform the doctor or the nurse about this particular value. So that should be entered. And the next step is, if it is an inpatient, the nurse will then inform the doctor. So it is again the nurse's responsibility to note down this in the notes that I have received the critical value from the lab at this time, and let's say at 2:30 a.m. At 2:35, I call the doctor to inform about the critical value. So this also should be documented in the case sheet. So next step will be the is to execute the doctor's orders. So once the information is given to the doctor, say for example, maybe it is low potassium, The doctor may say, no, give this potassium correction, so many milliequivalents in so many ml of saline, and run it over this period of time. Take down the verbal order, though it is a high risk medication. You should be careful about it. Certain high risk medications cannot be given by telephone order. So the solution to that is, if the doctor is not available in the hospital, then that doctor should call the duty doctor in that particular hospital and give that order to him or her, and that duty doctor will come and write it in the particular patient's case sheet. So that order should be executed. The next step is to repeat the test. So after doing the correction, maybe after 2-3 hours or whatever the time scale is, you repeat the test to make sure that that critical value has come down or gone up, and that is when the cycle is completed. So, I this is the reason why many hospitals get an NC in NABH, because some part of this is missing. And the assessors are pretty, they have seen so many hospitals, they are very experienced and smart. So they will come to the lab and say, can I see your critical value register? So they will look at the register. And then they'll note down a couple of hospital numbers from that register, which happened in probably the last 2 or 3 weeks or 1 month. And then when they go to the MRD, they will ask for these case sheets. And then they'll check whether the nurse has written down the time of receiving the order, the time in which the doctor was informed, and the time in which the treatment was started, time the repeat test was done, and the values are written there. So this is a proof that based on a critical value, you have done certain actions to make sure that you have treated the patient and prevented them from harm. So this is the proof that actually you are practicing the critical, the actions required when you hear a critical value. So this is more important. So now just having a critical value register is not sufficient. The whole system should be primed so that the action happens quickly, so that the patient's condition is corrected. So that's very, very important to know. And because of this lack of understanding, you may do all these things but not document it. So when the no documentation, as they say, what is not documented is not done. In legal parlance, judge will always say, no, 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 I done this. If the doctor argues, they will just say what is documented is not done. So same way, when you go for an assessment, what is documented is not done. So have these documentation principles in place. Involve include them in your training to the doctors, the nurses, and the lab personnel, so that this documentation is done.
And this is again about, yeah.
This is a question which is, the poll this came up. So, I'm finding that I'm not able to contact the doctor. So have an escalation, code, escalation clause in your SOP. So if you contact the duty doctor who is available in the hospital, what is the maximum time you can wait before escalating? We are just given an example of 15 minutes, but in certain cases it can be just a few minutes. It depends on the urgency of what the lab value is indicating. So you need to have an escalation clause, and if that time is gone, then the nurse is empowered to inform their seniors and also to contact the primary consultant or the ICU consultant directly. Okay, even if this is not possible, then it should be escalated to the department head. Even if this is not possible, then the medical director, the ultimate authority for the hospital, has to be informed. So if you include this escalation matrix as a clause in your SOP and also empower your nurses, then it doesn't matter. Even if your immediate doctor whom you want to contact is not responding, you know what to do.
Yes. I think the poll question have been answered, Dr. No. And we have one case study, and I'll tell you that before this, once you have understood this, I wanted all the participants to drop your answers in the chat box. What you will will be doing. So this is the case, like the silent hypoglycemic crisis. This is the patient name Mariam, 45 years old. She is a type 1 diabetes patient, found confused at home. Okay, this is the case. So her blood glucose shows like 28 milligram per DL. She has sweating and she is no shaky. And then the family also like acting, saying that she's been acting so strange for some hours. And what are your immediate priorities? Imagine you are in the particular unit receiving this patient, and this is the case you have found now. So what will be your immediate priorities for this patient? So if you could drop down your answers one by one in the chat box so that we'll be able to understand what can be done. So inform doctor and cannulation. Mr. Shafiq have said, and Ms. Manimegla have said 25% dextrose she will administer, 100 ml given, and administer D5. Inform doctor, correct the sugar level, and oral glucose can be given. Sorry, I'm not reading out everybody's name because a lot of comments are coming. Administer 25% dextrose, provide sugar, immediately give sugar.
First.
Sorry, sir?
One person is saying stabilize the patient first.
Stabilize the patient first, okay. And inform the doctor immediately. Most probably like oral glucose is given.
Yeah, it's moving so fast, it's difficult to read. So many
Yes,
people.
yes.
Thank you.
Inform the doctor immediately hypoglycemia and cannulate the patient, correct glucose level, inform doctor, okay. Any sweet items, give with safety, please. Oh my God. Okay, and 28 is very low and risk for arrest. And dextrose 5 with human mixture 8 units added and IV infusion. Stabilize the patient and oral glycemia need to give. Yes. Shoot IV 50% glucose. You're going to shoot? Okay. Oral glucose inform to doctor. Okay, sugar can give. Okay, sir. So I think thank you so much for all your immediate action. I think everybody have taken up the charge role now. So I have treated the Mariam. Can we see step by step now what is actually like expected to be done? Can we move to the next slide, sir? Proceed further.
Yeah, please go ahead.
Yeah. Yes. So somebody said like stabilize the patient. Am I right, doctor? Like secure the airway. Do you want to take up this, Dr. Pari, so that you can tell us? Yes.
This is an emergency. As I think so many people pointed out in the chat, it is imminent that patient may have an arrest. So we need to make sure that we are stabilizing the ABCD, right? So that is very, very important in any emergency. So airway and breathing. Though you said airway, it's airway and breathing. So make sure the patient airway is clear and stable. So the next is the circulation. So establish an IV access if you can. At home setting, obviously, if your nurse have been called, you probably have gone in an ambulance and you got the IV cannulas and all in your hand. You can establish an IV access and set up an IV medication administration. The third is the level of consciousness. So you need to assess whether the patient is conscious or responding or totally unconscious. So that will also indicate the emergency and the route in which you're going to administer the sugars. So that is the first priority. You have to stabilize the patient and take care of the ABCD. So the next step is to, as again, so many people in the chat pointed out, you got to immediately rush the 25% or 50% dextrose. It is IV is where is the preferred route if the patient is unconscious. It all depends on the hypoglycemia is a spectrum. So as we said in the case summary, just a strange behavior could be the initial thing, or the patient has become unconscious. So depending upon the conscious level of the patient, you have to. I think you will not administer IM or subcutaneous. I don't know how that came in here. I think our quality assurance team is not looking at
I
this.
think it have not checked. Yeah.
You need to be, check this more carefully. So it is
Yes.
IV. I'm sorry that this mistake has happened in this slide. It's because a very, very crucial piece of information. So this 25% dextrose should be given IV. So next is the if as again if this is home, patient is conscious, able to swallow and not get into aspiration. I'm talking pulmonary aspiration. Then you can give sugar. A simple thing will just to mix the sugar in water and give it, and that will really raise the blood sugar. Or if the patient is not that hypoglycemic, even sweets and chocolates will do the trick many times. So that is the fast acting carbs. Now you can't give very complex carbohydrates. Just plain sugar will do the trick. Next action is to recheck. So if you have a CBG machine, so recheck the sugars to make sure it is calm. Don't get alarmed if the sugar goes up to 300. No problems. We can control. Patients are not going to, because it's an immediate spike which you gave, and it will settle down. Okay, so that is how you manage this patient in a very methodical way. Is there any more slides, or you're? I think yeah.
Yeah, this is about the continuous monitoring.
Yeah, so then you recheck the blood glucose and continuous monitoring. I think if you think the patient is unconscious for some time, then definitely you need to shift the patient to the hospital. Otherwise, you monitor them at home and make sure they're stable. Educate them on maybe if they are taking anti-diabetic drugs without eating. Maybe they recently gone to the diabetologist and changed the dosage. These are things which need to be looked at, and you give them the education and also fix an appointment with the physician at the earliest. But if they are unstable, shift them to the emergency department.
And the final one is like investigate the underlying cause. So after the continuous monitoring, I think they have to collaboratively work with. So here, it's like when Dr. Pari is explaining, more or less, it sounds like a standing instruction. Am I right, sir? So this is how, like, every hospital can even have a standing instruction when the critical alert comes, like what they have to do. So that is like something different with the different management, different consultant have the different point of view, like how to treat their patients when the critical alert comes. So this is one example with the scenario. I think you all would have understood what has to be done. So we have come to an end. So summarizing with this, like recognizing the life-threatening lab values immediately, it is very crucial and it's very important. And also informing the the escalation protocol must be in the structured format using the ISBAR format, like talking about the current scenario, the background assessment, and the recommendation. Instead talking too much about the information, to the point how we are going to figure out with us. So we have seen about that. And also document everything with precise timing, as even doctor have highlighted points like when you have received the value and when you have informed the doctor. That is very important. Even the 5 minutes gap and the 10 minutes gap can do many things with the patient. So it's very important you have to document the two timings, and the timings, it's really to be noted. And escalate appropriately, like when the like no a particular doctor whom you have to notify and he is not picked up the call, what to do immediately. Now you all know what is the escalation protocol, what has to be done. So this is all thing. So as you all know, this is the first image you would have seen. A nurse who was like very anxious looking into the lab reports, how she was like no dull, upset, anxious, what to do with it, actually what is actually happening with the lab report. The second image, no as you all know, I can see, I think everybody is smiling now after knowing all the critical lab values, what has to be done. That's the thing, the impact what you're going to have in your practice. So this is about like today's session. So I think if you have any no questions, we can start off with the Q&A session.
Yeah, before we start the Q&A session, I think I agree with I think Preetham, who said that the case vignet was very disorganized and not done properly. I think our development team and the quality assurance team has to be more careful. So especially when you're discussing such an important treatment protocol, you can't put on the slides things which are completely inappropriate. And ultimately, I need to take the blame because the buck stops with me. Being the founder, I sincerely apologize for this way in which the case discussion was handled today. Our apologies. We will make sure that it doesn't happen in future. Yeah, you can go ahead with the quality assurance. The Q&As.
Yeah, okay, doctor. I'm equally sorry for it actually. So we'll make sure this is not happening again. And okay, so there is one question from Shreya Achrekar. Do we need to maintain register for critical lab values?
Yes, I think I already pointed that out. It is usually in the lab. This critical value register is in the lab, but if you want to maintain one in the ward, yes, you can do that. I think that's also good practice.
Yeah, yeah.
But more
And
than the critical value register, it causes duplication. No, again to do it in the ward. So it is, what we do in our hospital is to make sure that the documentation is done in each and every patient's case record. But because many times for NABH, what we do is we will increase the documentation, and that unfortunately puts more pressure on the nurses. So if it's absolutely necessary, go ahead. But otherwise, documenting in the case sheet is good enough.
And Dr. Babu Balakrishnan have asked, while receiving the critical value, in which form the nurse should document the same? Documentation part, I can tell it up, Dr. Pari. It is actually when they're receiving the critical care value, they can write it in the doctor's reassessment sheet. Because it is again, they have to communicate with the doctor. Most probably, many of the hospital, they have started to use the critical lab alert seal. So where, am I right, Dr. Pari? They have a seal where they will seal, and then what is the critical lab value, what they have received, and who have witnessed that value, which is, so that again that seal will come in the reassessment sheet. So anything
Again,
else from your side?
can't give one answer for that because the protocols
Yeah,
vary.
it depends on the protocol, hospital protocols, so it depends upon, like, if many of the hospitals does this and some will documenting in the same nursing document itself.
It all depends
So
on the hospital
yes,
protocol.
depend on the hospital protocol.
Basically, it should be
And
documented and so that it can be easily verified. So that's all.
yes, yes. And okay, in all critical values, readback mechanism should be followed.
Yeah, we
Yes.
didn't get into that because it's
Yes.
every lab value or critical thing has to be read back. That should be in your communication SOP.
Yes, yes. And Pratipati Usha Rani have asked, like, is there any ISBAR form? How can we write it, ma'am? Please, can you tell me? So I think we have given a one example slide, but that is very, like, with minimal information we have given. Probably I can help you out with the template. Is
We
that
have,
okay, doctor?
we can go to please go to our YouTube channel. We have done a whole
Yes.
webinar on this bar in the past. So please
Yes.
for that, and you can listen to it. And there, I think, or you can in our WhatsApp group, please share this bar template.
Yes,
So we can
I
do that.
could possibly do that. And equally, to know more about the ISBAR session, as Dr. Pari have said, you can go into the YouTube channel, you can watch that, so you will have a whole understanding. And and there is another question from Kirti. Do we need to inform abnormal value? So because we were talking about critical value, she want to
Sorry,
know,
what
like,
was that again?
do we need to inform abnormal value?
No. Then it becomes, you can handle it. If you are starting yeah, you will inform the, abnormal value, no doubt about that. But it
Yes.
doesn't, today we're talking about critical values, the process of doing it. Abnormal values, yes, but that, is not that critical. No, we are talking about time critical tests here. Yes, the simple answer is yes, you will inform abnormal values. Yes.
Yes, yes.
Now, I was just
And
reading the comments. That's the reason I was a bit distracted.
okay, okay,
People
sure,
are
sure.
sharing their best practices also. So please
Oh, okay.
read that as well, right?
Okay.
Yeah.
Let me complete this Q&A portal.
Yeah.
One thing is, like, after giving education to staff about reporting lab values, how to make sustainability and to make the nurse to habit in doing a proper documentation of lab values. That's again, like, do you have any suggestion? Tell them. I think
It's
they have
not.
to audit the files, no, sir?
Yeah, it's not just a nurse. It's just,
Yes.
this is, there are two things. One, you could probably do a clinical pathway for critical results, so that you involve the lab techs, the lab personnel, the nurses and the doctors to get involved to put the process in place. And then, as Stella pointed out, audit whether this is happening after a month or so, and then keep auditing on a regular basis. So this is the way to, as any other quality improvement project, you can do this.
Yes, yes. And Mona Ghosh have asked any opinion about automated alerting system?
Yeah, we didn't talk about it now because
Yes.
a lot of tech solutions are available. We consciously left it out in our webinar because we just wanted to look at the process. See, technology helps to a certain extent, but once like for example, you could have an phone app which is connected to the auto analyzer itself. So once the critical alert, I mean the
Yes.
lab value, critical value comes, automatically it alerts the whoever you want to designate in that particular app. This is the fastest way to do it. Definitely, technology is a great enabler. I believe in it, a lot. But there are some times where we have to talk to humans and say, "This is important. Please do it." So that's the reason, no, we didn't highlight that. Please, use technology to enable this, process.
Okay. And there's another question like readback value has to be recorded too. Like recording in sense, you will be documenting, writing down like what the order you have received and no. Am I right, doctor? Like recorded in sense, like no, two persons will be receiving the order. So one person will be, receiving the order, writing down. Another person will be witnessing like the same order you have received, you are writing it down.
I don't think that sort of process is mandated. Uh,
Okay.
See, the another problem, no, this NABH causes a lot of such complications. One, as I said, is over documentation,
Yes.
and making your processes very complex. So keep it simple. It's not the KISS principle, right? Keep it simple, comma. You can put whether you want stupid with a comma or not. Okay.
Okay.
Keep it simple, stupid, or keep it simple, comma, stupid. So I would not, overcomplicate it. No, make sure that this is taught to everybody. Everybody follows it.
Yes. Yes.
You can argue against me.
No, but still, what they are receiving it, I think they have to document, doctor. That is
Yeah,
the
yeah.
simple.
Documentation enough,
Yeah.
but having another
Yes.
person to verify and all that, no, complicates.
Yes, it's quite, yeah, yeah. Now I think then many of the nurses' minds they'll be having already the attrition rates are very high. One nurse taking care of like how I can even lend another witness nurse. I can hear to all the mind voices. So then now it's like, what's the recommended time for intervention?
No,
So
I mean, you can't tell that, right? It all
yes,
depends on the particular value. Okay, so it's ASAP, as soon as possible. But if you want to put timelines, depending upon the lab results, say for example, if it is a cerebral hemorrhage in imaging, I've told you, imaging also has got critical values. So
yes,
that is like it has to be done as quickly as possible. And you do an audit and see that whether no that is done as quickly as possible. So again, it varies from hospital to hospital, and if you want to put timelines, go ahead. But again, as I said, make sure that you don't overcomplicate these protocols.
yes. And yes, doctor, can I go into the chat box because
I think there's somebody raising hands if they want to comment or ask a
yeah,
question.
yes, you have given them. Okay. Meanwhile, this Q&A session is going on. The feedback form link has been posted in the chat box. You can click that form and then you can fill it up so that you will get the certification of participation to this webinar. So,
I think there's
so
one
we'll continue with
Dana
this.
Lakshmi who's raised hands. You want to say something?
Yes. So you have given access to unmute yourself, Ms. Dhanalakshmi. You can unmute and then you can talk if you want to ask anything directly.
Your time starts now.
Okay.
All right.
So,
Go ahead.
yeah. Okay. Yeah.
Are we done with all the questions?
Yes, I am into the chat box.
Okay.
So they are just, as you have said, they have no shared. For your thing, no, and Susan, not interested in doctorship but in nurses progression. Of course, that is what. No, I think this is the comment they have left after my suggestion. So it is like hospital, the norms change. Where you're going to document that critical lab value which you have received in over the phone. As Dr. Pari have said, it depends on the hospital policy. And one of the Ajit Peter have said, like, we do it by logging the relay details against the critical reports before final release. Once in a month, these values will be verified, it seems. This is their practice, like what they do. Readback time mentioned in the record is mandatory, or only like yes or no is sufficient? So this question.
What is that? I don't understand.
Yeah, even so, I think read back time mentioned in the record is mandatory, or only yes or no is sufficient. Means, what do you mean actually?
Receiving time, yes, you have to.
Yes.
Just 1 minute.
Yeah.
Yeah, receiving time has to be noted.
Yes.
I think when who, I don't know who's the comment from.
Yeah.
They
If you
meant
want
very
to
well.
ask directly, also something to
Yeah,
clarify,
he
because the
meant
question is not.
receiving time, yes. Read back is just a process, right? Yeah.
Okay. Or no, yes or no sufficient. I'm not getting it properly. Miss
Yeah.
Preeti
Don't understand
Vishwanath
that.
again.
Please,
Yeah.
yeah.
Yes.
You can
And
unmute and no. Talk.
mm, yeah. Okay, how about documenting critical value in different color pen in investigation chart and the correction given for it, ma'am? So they have asked like that. So that is again, the hospital practice. If you really have an saying that you have to document different color pen, then you will do it. But what is your opinion, doctor, about this?
See, in my opinion, adding layers, thinking that will solve the problem doesn't solve the problem. Especially,
Hmm.
you said rubber stamp and this one, color pens.
Mhm.
All this is adding layers.
Yes.
Whereas what we need to focus on is educating, the staff, making sure the process is audited, keep on, repeating the education and reinforcing it in your training. That's what
Yes.
works, ultimately, I think.
True, true. So okay, like another question, Miss Bhaglakshmi have asked, before informing the doctor about the critical lab value, do they have to take the printout and then check it and then inform?
No, no. I mean, that delays, right?
Yes.
I think verbal report, as long as you followed the readback policy and you've taken it accurately, that is enough. No need to wait for the printed report. Sometimes that gets very much delayed.
And I think towards the end, it is about like, I think I've covered out all the things.
Yeah, thank you so much for. I
Yeah,
mean, really,
yes, yes.
overwhelmed with so much of participation by a view of comments and questions and answers. And Preetham, I think we don't take offense at all. I mean, criticisms are necessary for us to grow. So please don't feel bad about it, and please, tell us what our mistakes are, and we will correct it.
It shows how much you are connected with us, like no, to show off us like what is actually missing, what is your expectation also. So we are all here to know, get it done like in the way you all are like expecting. And no, sorry from my side even. And I think all the participants, today I was very happy, doctor, because everybody was equally participating in the chat box and the Q&A portal everywhere. and a lot of the interactions were made very possibly because of the active participants. Thank you so much to you all. And also I just want to highlight one thing I saw in the chat box. Two
Yeah.
three questions were no stating my name, saying like where is my certificate for the past two webinars. If you have filled the feedback form and still you haven't received the certificate, then you can call our Jayanti and then get connect with her so that she can help you out, probably in getting that sorted out very soon. So you can. So, and for today, even for all the webinars, at the end of the session you fill the form, so within 48 hours of time you'll be getting the certificate. For in terms of last few webinars, what about 𝐔𝐬𝐽, we had like more number of participants, so it was getting delayed like by another additional 1 day. Like after 3 days you were receiving the certificate. I think if you have really filled the form, you can contact our Jayanti, she can help you out, so no worries for that. We are there to help you
And
out.
I think we should, I will encourage all of you to visit our YouTube site. There's almost like 60 plus videos of our past webinars there. So it's
Yes.
quite a good collection of learning material available there, all for free. So please,
Yes.
feel free to subscribe and to our YouTube channel. So that helps us to spread the message, even further.
Yes.
There was a
Yes.
comment, in the previous webinar when we are reaching so many hospitals. They said, "Why are you limiting yourself to so many hospitals?" We are not limiting. I think we need to, and the electronic and digital media is the only way we can spread to much, much more hospitals and people. So people who attend the webinar, please, also visit our YouTube channel and subscribe. It will help our webinars to go much, much further. And if you're benefited, please, do that. Thank you so much.
Thank you so much, Doctor, and thank you so much to all. So you can fill the feedback link. This Zoom room will be like open for another 15 to 20 minutes. You can utilize the time to fill the feedback form and then slowly. So thank you for all your participation. Thank you, Dr. Pari.
Thank you. Thank you so much. We'll meet next Friday. Thank you.
Yes, thank you. Hello everyone. Like I just got to know like there are a number of participants who have equally joined from our YouTube live. So what you can do in the YouTube, again in the chat box we have put the feedback link. You can click that form and then you can get the benefit of the certificate of the participation to this webinar. So no, you don't have to worry. The feedback link is there in the YouTube chat box even to for the easy access of for all of you. Thank you so much.